Ask Sergio. He's done that, I believe.
Yeah. So, Becky, May, Jay, welcome aboard. So we're just waiting for another couple of minutes, just to let as many join as possible. So we are like 3 minutes past, so maybe just another 60 seconds, and then we'll crack on. All right, so we got 13 participants here already, and I think, Ahmed, your celebrity aura is working. Okay, so welcome everybody to NeoFOCUS' weekly Friday presentation. Today we have the privilege of having Dr. Ahmed Moharam with us, who's going to make us wiser on a very interesting topic. Ahmed Moharam, he's a great trainee in the Northwest, already a distinguished neonatologist, and he's going to speak today on something that all POCUS people keep asking the question about. It's about pneumothorax and the decision facilitated with regards to conservative versus invasive management. He'll let you know. Just for housekeeping, once he finishes, please raise your hands and keep your mics off. Yeah, we'll have questions and comments in the end. So Ahmed, floor is yours. Please crack on. Thank you.
Thank you very much, Sheril, for the introduction. So the topic of today is about pneumothorax, and it's about if ultrasound can help us taking a decision, either wait and watch or stick a needle into a baby, and both decisions are far different. So a bit of just a second. Moving now. Okay. Okay, moving on. So the objective of today is about lung ultrasound in diagnosing and guiding the decision of air leak management in neonates. And do we have evidence in neonates? So today is not about critical appraisal of evidence, but we will touch base about evidence. And I'm going to present a few cases. I have 7 cases to present. All are real cases, all my images. So feel free to comment, give advice, or if you have tricks on how to do things differently. And then eventually I'm going to reflect and comment on those images and those cases and try to reach to a conclusion on strengths and limitations of lung ultrasound in air leak in neonates. So a bit of background. So I finished my pediatric residency in Egypt, and I moved to UAE, where I did a neonatal fellowship in a tertiary neonatal unit. And in 2018, it was my first lung ultrasound course by Dr. Yasser from Canada. And then I moved to the UK to join the pediatric training in Aberdeen, where I was privileged to get a lot of support by my colleagues, juniors and seniors and consultants. And I was inspired by Shergil, who was doing lung ultrasound on daily basis, diagnosing effusions and very nice pictures. So I started to develop this area of interest, and I had another course with NeoFOCUS group in Glasgow before I moved to Northwest, where I started to practice more and more cases. So back to the evidence. In 2016, looking at this paper, they have done a lot of work to come to a conclusion that the lung ultrasound is excellent for detection critical ultrasound in decompensated neonates. And it's specific and sensitive, as well as X-ray, if not more. And then more and more papers started to come in 2020. Then another paper about the use of lung ultrasound in early detection of pneumothorax. And also they came to the same conclusion that lung ultrasound is even superior and more sensitive and specific compared to chest X-ray. And then 2 years ago, the American Academy of Pediatrics, they have published their guidance on lung ultrasound in diagnosis and procedural purposes. And they set 4 criteria, which we will go through it. Absence of sliding sign, complete absence of P lines, presence of lung point, and barcode sign. But actually, the aim of this publication was targeting infants that are unresponsive to positive pressure ventilation and fluid resuscitation. So crashing newborn babies. And they recommended lung ultrasound and then focus cardiac echo and then intestinal ultrasound and then abdominal and cranial ultrasound in a very nice algorithm to rule out the common things. I will focus on the lung ultrasound part of things. So lung ultrasound in a crashing newborn baby can help you to diagnose collapse consolidation, and then the action would be to adjust your ventilator parameters or consider surfactant to open your lung, or it can diagnose pneumothorax and air leak. And then the recommendation here is needle thoracentesis, or it can also diagnose effusion, and the action here would be again needle thoracentesis. So all those actions are quite invasive, but also here we are dealing with a baby who's crashing, not responsive to pressure ventilation and not responsive to fluid resuscitation. But again, what about the baby who's started to have increased work of breathing and X-ray showed a picture of pneumothorax, or a baby who started to have increased oxygen requirement or increased pressure to achieve the targeted volume, and then your ultrasound or X-ray showed you signs of pneumothorax? Would you stick a needle for needle thoracentesis, or would you watch and wait? This was my question based on the cases that I have been through. And then the NeoFOCUS group, they published a very nice framework as well, and they have given us some guidance that ultrasound can guide on invasive procedures, just like chest drains and endotracheal tube position. And they refer to one article which showed that assessment of pneumothorax and pleural effusion could be done, and there is possibility for semi-quantification of pneumothorax or effusion, and this should give a guidance on chest drain and removal of chest drain, which was quite nice. So I went through this paper, and it is an international expert consensus, and they recommended one of 3 options. Your pneumothorax is mild if it is if the signs of pneumothorax are at the anterior chest, the part of the anterior part of the chest, or moderate if it is in the anterior and lateral part of the chest, severe if it is anterior and lateral and posterior part of the chest. This could be helpful, but okay, I'll see if this is applicable to the cases that I've seen. I don't find a landmark to tell me if the lung ultrasound as a tool can tell me, okay, intervene or not to intervene based on this. But still, it's one recommendation. I have seen other recommendations, but all related to adults, different lung pathology, different size. Um, 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 Talk about a lung point lateral to the mid-clavicular line, which I find very challenging to achieve in a newborn baby. But this is my question actually of the day. Can lung ultrasound give us a objective um, um, measurement or landmark where I would say I'm going to stick a needle or I'm going to watch and wait? So the technicality of lung ultrasound is not in the scope of this talk, but I will quickly go through it because we have different levels of experiences. So this is our way or my way of doing lung ultrasound. I try to find the path and then the pleural line and comment on the pleural line and then A lines and B lines simply. And then when I look at the pleural line, I need to comment if this line is moving, shimmering, because the both visceral and pleural lines are moving in different directions. So it should give us this shimmering action. And then if the lung is well aerated, we will not be able to see any organs which are not in contact with our pleural line, because the rest of the image would be the reflection or reverberation of the pleural line, which we call A lines. Then, in case of any interstitial or alveolar lung pathology, whatever it is, this will give a media for the ultrasound beam to travel through, which will give us what's called B lines. So, very basic: path, sign, pleural line, moving or not moving, A lines, and how many B lines do we have? So B lines, uh, we were told that 2 B lines are normal. More than two we'll consider abnormal. More and more B lines, they will start to coalesce, and they could reflect um, interstitial pathology or alveolar pathology. Again, it's not the scope of this talk, but just to make sure that you are speaking the same language. Okay, so you got your PAT sign, you have your two reps, you have your pleura. You need to see your pleura moving. You need you need to see your A lines. If you have B lines, mean that there is some sort of media allows the beams to travel through. So this means that there is no pneumothorax. So let's see what we have here. So we have the reps, we have the pleural line. It's not moving, it's static. The whole lung is static, and all we can see is A lines, and we don't have any B lines. And this pleura is not moving. The baby is moving, or this is the beats of the heart, but the pleura itself is not moving. Okay, so we have here a suspicion of air leak because we don't have any B lines. We can argue that we don't have the pleura moving. So we need to confirm that. So the next step is to look for the lung point. So the lung point is where the lung parenchyma meets the area of air leak. And it has a very characteristic picture of pleura, which is not moving, and lung, which is very static, and all of it is just a reflection of this pleura, no B lines at all. And at this point, you can see that there is a lung parenchyma. Usually there's some sort of atelectasis, but the pleura here, you can see it's shining and moving, and there is on and off B lines coming and disappearing. So this means that this area is just air, and there is no parenchyma. So the visceral and parietal pleura are separated. And what we can see is a pleura which is static, not moving, and the reflection of this pleura in the air. And at this point, we can see that the lung parenchyma started to, to, to come to the view, where B lines are able to travel through the parenchyma, and we can see the pleura is moving and shining, and we can see B lines as long as A lines as well. And then we need to confirm the fourth sign, which is another mode. It's not the T2D mode. We need to switch to M mode, where we can see either seashore sign or barcode sign. Not usually as beautiful as this image, but in the seashore sign, because the lung is moving, so it will have an appearance of seashore because it's very hazy. It's a moving tissue, and then the pleural line, and then straight lines, which is the subcutaneous tissue. Where in the barcode sign and the pneumothorax, we will find everything is just like a barcode, like lines, because the lung is not moving, it's just air. The pleura is not moving, and the soft tissue is not moving as well. So when we go back to our lung point or area of suspicion of pneumothorax, we need to put the M mode and look at the barcode sign or seashore sign to confirm. So now if we have the four signs, if we have the pleura not moving, absence of P lines, no P lines at all, and if we need to move our probe to look for the lung point. If we find the lung point, That's very, very specific, very sensitive to the diagnosis. And then we can switch from 2D mode to M mode to look for the barcode sign versus the seashore sign. Now we'll start with some cases. So I have around 7 cases. Um, I'm not sure what will work best, like to comment after every case or just to comment at the end. Um,
Um, I think if you really have 7 of them, then just speak through.
okay. All right. So not the 7 cases are pneumothorax. The 7 cases, is just my reflection on the cases where pneumothorax was suspected or other signs that looks like pneumothorax. Or there was a confusion about the decision to intervene or not to intervene. So I hope it will be like an interactive at the end because I want to learn from my experience as well. So again, all of these ultrasounds are my ultrasounds, so feel free to comment, agree or disagree on the findings. So the first case is a term baby, normal delivery, normal Apgar, no resuscitation required. Mom was pyrexial, so that's why to monitor the baby. And then at 6 hours age, it came to our attention that on regular monitoring, saturation is below 90%, and baby started to be more tachypnic. So as a term baby, admitted on CPAP, 6 centimeters, oxygen requirement below 25%. First gas, as you can see, fairly acceptable. Second gas repeated after 1 hour of admission. We still don't have an X-ray, still barely acceptable. Saturation is still around 25%. Baby's hemodynamically stable, and this is the X-rays that we had. So the X-ray showed right side pneumothorax and a term baby vigorous on CPAP. So at this point, as a very enthusiastic trainee at the start of my training with a very little experience, I started to put the probe and look at the ultrasound. Baby was stable. I just want to try to quantify the pneumothorax to guide my decision. And this what inspired me to keep going with this and try to find an answer. So let's look at the finding. That's R1. What we can see here, we can see all A lines. If you agree, if you disagree with anything, please let me know. I cannot see raised hands, by the way. So all I can see is pleural line, which is thin, but it's not moving, and reflection of that which A lines, and I cannot see any single B line. Okay, that looks like an pneumothorax. Let's go down a little bit with the probe to look for R2. Very similar picture. No single B line. I cannot see any lung point. This is at the mid-clavicular, where I was taught to start my scan with. So very similar picture. It looks like an air leak. Let's do the complete our work and do the M mode on this area. And as you can see, it looks like a barcode, all transverse line. Okay, it's pretty much a pneumothorax. Not a surprise. We know already from the X-ray. Okay, so what's next? I didn't look for the lung point at this point. I was not sure what does the lung point mean. This was like 7 months ago. So I did uh, uh, um, R3, and as you can see the difference here, the pleura is moving very nicely. You can see the comitails or B lines together with the A lines. So this is a well-aerated lung. Do you think this is pneumothorax? Don't think so. Pleura is shining, moving very nicely with the P lines on and off and reflection of A lines, which tells me that this lung at the lateral side is very well aerated. Okay, then let's do the, as I was taught, do the M mode at this part, which was what looks like seashore. It's not all lines. It looks like a seashore, and you can see on and off there's somewhat called lung pulse, which also excludes pneumothorax. Okay, so I have a pneumothorax in the anterior part of the chest, and I don't have pneumothorax on the lateral part of the chest. Okay, can this help my decision? I was not quite sure, to be honest. I had a very supportive consultant who was happy for me to do the ultrasound, but then we discussed, and the decision was baby was really tachypnic. I know the oxygen requirement is not high, gas is really good, but it's term baby, tachypnic on CPAP, work of breathing can increase. Let's intubate and drain this chest drain, this pneumothorax. Okay. Um, but before that, I did also the left side. And as you can see, it's very well aerated lung. You can see it's very thin and healthy pleura with comitailins and B lines and A lines on the L1 and L2 as well. And L3, maybe L3 more B lines, but still it's a very well aerated lung. So I personally, I feel that the left lung looks healthy. The lateral side of the right lung looks healthy. The anterior part of the right side, there is a pneumothorax. Ultrasound cannot detect the depth of this pneumothorax. So I guess I didn't do the lung point, but even if I moved with the probe to like like lateral to mid-clavicular or anterior axillary, okay, here is the lung point. Okay, then what? What is the evidence to intervene or not to intervene? At this point, I didn't have evidence, and this was one of the reasons that I started to look at the evidence if we have anything to support my decision. Um, and also, I didn't see anything in the literature about commenting on other lung zones. So I started to question myself. So the other part of the lung looks healthy. So what would be the safest approach to this baby? Not to intervene or to intervene. So eventually, we intubated the baby with a chest drain, needed some adjustment, and then cleared. And as you can see, the chest drain clamped after 6 hours because baby was in very minimal ventilation parameters in air, and then extubated after 12 hours from intubation and chest drain was taken out. So this again started to tickle my mind, and I just started to reflect on this as I started to progress in lung ultrasounds. So I told myself, okay, so you need to look for lung point to complete your diagnosis of air leak. You need to have four things: pleura, which is not moving; A lines with no B lines. You need to find your lung point, and you need to confirm that in M mode. But still, my question is not yet answered. After that, I confirm pneumothorax. Then what's next? Okay, so I started to after and the following case started to look at B lines, and I started to realize that there is a limitation of ultrasound because how I will look at the depth. So it could be very superficial, but extending to the anterior axillary or mid axillary, or even to the back, but still could be superficial. So it cannot test the depth. So this is one of the limitation I started to think about. And also, whenever there is a pneumothorax, we need to take into consideration the aeration of or collapse of the rest of the lung zones. If this pneumothorax is deep and extended, it will collapse the rest of the right lung, or may even cause mediastinal shift with what we see in the X-ray and collapse of the left side. So it's really important also to take into consideration how the other zones of the lungs looks like, which I couldn't find in the literature in the neonatal age group. Another case, so this is a 16 days old baby with duct-dependent cyanotic heart disease, pulmonary atresia, hypoplastic right ventricle with intact septum. So no need to go to hemodynamics, it's not our scope, but this baby was on CPAP in air on Prostine. And there was a planned CT with breath holding. So that's why this baby was electively intubated. And after intubation, this is the X-ray that you can see. Baby was actually in very low parameters, just 4 ml per kilo volume and air still. But you can see there was area of suspicion here, and there is also area of suspicion here. So it was not quite right X-ray. Baby was still stable, but within few hours, baby started to have more desaturations and blood gas, which was respiratory acidosis, not very acidosis, but CO2 has increased to 10 and then 12. Baby never had a gas like that. So there is something wrong going on with the lung. So the X-ray was repeated, and unfortunately the CT was abundant. We didn't do the CT. Baby was not very stable, having more desaturations, and we had actually to go up with the ventilation parameters a little bit cautiously because we are suspecting air leak here. So we went up with the volume, and after discussion with cardiologists, they were happy to go up with the oxygen as well. So there is escalation of respiratory support because this baby was electively intubated, but now we have to go up with our parameters and our oxygen, and there are X-ray changes. Okay, so this is my time. This is the latest ultrasound I've done. So probably I hope that I have developed some skills now. So I thought, okay, let's try to use the ultrasound to try to draw a picture of the lung. Although that is biased because I can see the X-ray and I can see already there is some sort of air leak. So at the mid-clavicular line, as I usually go, I put my probe, and then the pleura is moving, thin and shiny, B lines, some A lines here and there. Cannot see any pneumothorax. And then I went to the R2 as well. Same picture, moving pleura, thin and shiny, B lines on and off, and A lines, and I cannot see any lung point or and lung looks well aerated as well at the right side. And then uh, R3, this is not mid-clavicular, sorry, this is mid axillary. And then R4 is a little bit of effusion here, not massive, not apparent in the X-ray, but now I know that there is some effusion. Okay, then what? I cannot see air leak on the right side. So shall I confirm and document that I cannot see any air leak? I cannot see any pneumothorax. So I don't need then to look for the lung point, isn't it? Because I have done my PET. But in fact, I knew from the X-ray that there was suspicion, so I went to the parasternal line, and that's what I saw. So again, typical picture of pleura, which is not moving, all A lines, no B lines, and the mirror image of the reps, which also one of the signs of air leak. So there is air leak at the level of the parasternal line, and there is no air leak at the level of the midclavicular line. So if I didn't search for it, I will miss the small air leak. Okay, fine. And then I went in between the parasternal and midclavicular, and then I found my lung point eventually. So this is a confirmation that I have a pneumothorax or air leak, which I think it's a pneumomediastinum, and I realized that I cannot differentiate between pneumothorax and pneumomediastinum. And correct me if I'm wrong, but this is very medial, just lateral to the parasternal line, just lateral to the sternum. You can find your lung point, and if you continue with your probe till the midclavicular, you will have a very healthy, well-aerated lung. So it looked like a small air leak or small pneumothorax or small mediastinum, but I was confident that this probably doesn't need any intervention because it's small and it could have even been missed. And R2, same picture. If you go to the parasternal line, you will find your pleura not moving, all A lines, mirror image of the ribs, and no B lines. And then if you start to move again between your midclavicular and parasternal at the level of R2, below the nipple line, you will find your lung point diagnostic confirmed. There is air leak on the right side. I can report now my diagnosis. And if you can see here, the three parts moving from parasternal and between parasternal and midclavicular, you can see the difference clearly. So moving your probe also horizontally is really important if you are looking for a small early. That's the right side, okay. And then R2, what about R2? That's R1 still above the nipple line. What about below the nipple line? Just to look at the extension of the pneumothorax. Again, the midclavicular is very nice and no signs of air leak. And then lung point at between the midclavicular and parasternal, and then the parasternal is a typical picture of pneumothorax. And definitely, I confirmed that with barcode sign, just not to miss anything. So now I have the four signs that's telling me and confirming with confidence and with evidence, which is telling me that the ultrasound is more sensitive and specific than the X-ray, that there is an air leak, which I could have missed if I didn't move my probe medially. But yes, I report I can see a small air leak at the right side, could be pneumomediastinum or pneumothorax, which is not extending to the level of the midline. Okay, and then I confirmed the area at the midclavicular, and I can see the seashore sign. So there is no air leak at the midclavicular line. So I know now where is the pathology, and also I'm keeping in mind that the rest of the lung looks well aerated, so it's not affecting the lung aeration. And also I've seen a small area of effusion, so I'll keep an eye on that. And then when I left to the left side, uh, so at the started again with the midclavicular, I can see from the start, I can see the lung point, if you would agree that this is the lung point. Here is not moving, pleura, all A lines, and from this point, you can see starting B lines, vertical B lines at the midclavicular line. So it seems that's also air leak on the left side at the left midclavicular. Okay, so there is a right side air leak, and now there is a left side air leak. It's another picture. Now the L2 below the nipple line, and also you can see that You can see that the pleura is not moving here, and at this point started to move. So there's a at L1, at L2, so it's extending to the mid clavicular line, and it's from upper part of the chest and lower part of the chest. Again, I cannot comment on the depth. No one can comment on the depth. Is it superficial or deep? I don't know. So, but I'll keep in mind how the rest of the lung zones looks like. Um, um, so that um, L2 again. And then mid-axillary, R3, L3, well-aerated lung, if you would agree, moving pleura, air lines, and P lines. So there is no air leak in the lateral side of the left side of the chest. And then L4 as well, still the lung doesn't look collapsed or anything. Still the pleura is moving. Still I can see A lines and B lines. So I tried to make something like this. So I'm not sure if you would agree with that or not. So I've tried to make some sort of of a 3D image or something like that. So I can see a small air leak on the right side, more air leak on the left side, just at the level of the midline, and some effusion here. But the rest of the lung looks well aerated. So shall I stick a needle on this baby or no? And if I stick a needle, shall I stick it here or there? So challenging, but we haven't done any invasive intervention. The baby started to clinically improve. So the oxygen requirement came down back to air, and we started doing the ventilation. But on the following day, I was curious to follow up what is going on with this lung without an X-ray. So I've said, okay, let's see if the ultrasound could help me to look if the air leak is increasing or improving. So again, quickly, R1 started at the area where I know that there is a lung point. It's still there exactly between mid-clavicular and parasternal line. And at the parasternal line, it's still typical picture of air leak. So still probably right side uh, pneumomediastinum or slash small pneumothorax. But then I did one thing extra, the transverse view. So the transverse view confirmed also the lung point at the same area, at the same line. You cannot see any rips here, but what you can see is black, more blackish here. It's fluid. So I extended my transverse laterally, and this jellyfish sign is not at the R4, it's still R1, but laterally in a transverse view. So it seemed that the small effusion, which I saw on the first day, is now extending all the way up to the apex of the lung. Okay, so that's something new. So the air leak is at the same point, but now I can see more fluid accumulating. Why? Baby was looked at edematous, and actually baby was off a diuretic, and then we restarted diuretics. But we'll keep going with our ultrasound. I'll try to draw another picture before the X-ray, and I'll see if the X-ray confirms my picture. So then again, R2 below the nipple line, same lung point where I left it yesterday. And at the mid-clavicular, the lung is very well aerated and looks nice. And then at R3, at the mid-axillary, you can see fluids. You can see that the pleura here looks a little bit thicker, more interrupted, and now more coalescence of B lines. I'll give you the video of R3 in the previous day. Pleura look thinner. You can see clearly A lines, and the B lines are not very coalescent as here. So there is some sort of lung um, collapse, consolidation, and accumulation of fluid at the lateral side. Okay, so the picture is changing. And at the R4, at the costophrenic angle, you can clearly see that the fluid is more, and also there is some ascites started to develop. So the baby started to have um, fluids in the cavities, which may compromise the lung. Now, is this going to change my decision? Baby still in air, no escalation of ventilation parameters. But now, as a physician, I have a tool to tell me that there are changes that you need to be aware of. If there is an air leak already on the other side, which I'm going to look at, your right side started to accumulate fluids, and there is still small air leak there. Went to the left side. Again, the pneumothorax is where I left it. At the left mid-clavicular, I cannot see, this looks like an air leak. Sorry. And just now, just lateral to the mid-clavicular line. So we left it at the mid-clavicular line yesterday. Today, the lung point it started to be lateral to mid-clavicular line. So maybe a little bit more air leak. So it's not resolving at least. And if anything, it's more than yesterday. Okay, interesting. And again, confirm this with the barcode sign, just to keep all the signs. And then at L2 level, same sign, air leak. There's more fluids now, and lateral to the mid-clavicular line. You can see some B lines coming in the picture. So, okay. And then the left mid axillary, there is no signs of air leak. Pleura is moving with B lines as well, and L4 as well. So now I started to draw this picture. I'm not sure if you would, I was about to ask everyone to get a pen and paper and try to draw a picture based on the ultrasound and see if we'll get the same image, because that's how I try to interpret what's going on with the lung and if I need to intervene. So the air leak on the left side, I'm not sure how deep is it, but extending now just beyond the mid-clavicular line a little bit more. But the right side, the air leak is still there, still the same, but now I can see effusion from the apex of the lung down to the bottom at the costophrenic angle and ascites as well. So this baby now starts to be more and more vulnerable to complications. And this is the X-ray, this X-ray after the ultrasound. I'm not sure if it looks like the picture, which I've just shown you. No, but we did this X-ray just to, because it's still ultrasound in the process of guidelines approval and training approval. But we have done a lot of work on that. Hopefully soon we'll have a focus team in the unit. So this is X-ray. So this is one example of like just looking at a holistic picture of the lung using the ultrasound tool and try to draw a 3D picture in the mind. But there is no like cut off that you have to intervene now. My feeling is to look at you can try to have a 3D picture with your ultrasound and look at the other lung zones, well aerated, not well aerated, and how the baby looks like. Maybe the decision is not to intervene now, but now you know that this baby is vulnerable to complications. So if things changes in half an hour or 1 hour, put your probe and get ready with your needles. But your baby is not crashing at this point. So the way I concluded and reflected in this case is that lung ultrasound is diagnostic for pneumothorax. Yes, for sure. I use the 4 signs to diagnose air leak, but small air leak could be missed in lung ultrasound if you just scanning the mid-clavicular lines and mid-axillary lines. And also, can I remind myself to look for the lung point to complete your diagnosis and try to draw an imaginative 3D picture of the lung. This will help you to take a decision. And then lung ultrasound can aid the decision of invasive intervention versus wait and watch, taking into consideration clinical status or change in clinical status, and also respiratory support or escalation of respiratory support. For example, this baby, if there is any escalation of the respiratory support, I will have low threshold to take a needle. And then a lung ultrasound can help in follow-up of resolution or progression of air leak or fluids. And this was my reflection on this second case. And then third one, late preterm baby was antenatally diagnosed right side diaphragmatic hernia, was observed to examined lung to head ratio of 37%, bowel and liver in the chest cavity. The baby required, started with conventional, then switched to high frequency, initially needed 100% oxygen. And there was a wide gap between pre and postductal. Echo confirmed pulmonary hypertension. And after discussing the ventricular function and everything, the decision was INO, adrenaline, and milrinone. Following that, baby started to improve and oxygen came down to 45%. And we started to wean on adrenaline and INO. At this point, this is the first X-ray on admission, intubated at birth, because we know from antenatal already. This is the second X-ray. This is the third X-ray where I did the ultrasound. The reason for doing ultrasound, because actually not to diagnose diaphragmatic hernia. We know that already. But to look at the left side, because there was a suspicion again of air leak on the left side, we needed to rule that out. Okay, so let's see. So this is our right side. Okay, so the upper right, lower right, below the nipple line, and lateral mid-axillary. What you can see here, it's an A profile, isn't it? It's an A profile. It's a pleura, which is not moving. It's all A lines, no B lines, in the upper side of the lung, and the lower side of the lung, and the lateral side of the lung. But this is not a pneumothorax. These are bowel. So the bowel, if it's extended bowel, stomach, will give you the same picture of A profile. And then on R4, you can see the peristalsis and intestinal movement and lack of diaphragm as well. So on the right side, we know already this baby is a diaphragmatic hernia. Is it an air leak? Is it a bowel? So if it's a diaphragmatic hernia, A profile, most probably it's a bowel. So just in case, if you have a baby who just delivered, not very well, high parameters, you put a probe on, you found A profile, no B lines, static pleura, just A lines. Complete your examination before sticking the needle. This is my reflection, because you may see like an intestine, and this is probably not the lung. This is just a bowel. And then confirm it again. It's not moving. It's barcode sign. There is definitely no lung point. So from all over the lung, it's all A profile apart from R4. All A profile everywhere. Because if you look at the X-ray, that's how it looked like at the time of ultrasound. It's all bowel everywhere. I couldn't see the liver, because you cannot see an organ unless it's in contact with the pleural line. If it's away from the pleural line, you will not see it. So if there has a tumor or organ or whatever, not in contact with the pleural line, you will not see it. Okay, that's our right side. Then our left side, which was the question, do we have an air leak in the left side? So that's L1 at the upper part, and the baby is high frequency, as you can see, but the pleura is moving, a lot of B lines. You can see A lines as well, so nothing's happening here. And then I moved my probe a little bit because I learned the lesson. I need to look on other areas. So there is no, at the same level in L1, there is no signs of air leak. And then I did my homework and I did my M mode, and you can see very beautiful lung pulse, which excludes air leak. So this lung pulse is a cardiac pulsation, and if you see it, it's also against air leak. So if you have B lines, moving pleura, lung pulse, seashore sign, so there is no air leak on the left side, and this was a question and aim of ultrasound in this case. And then I completed on the L2 as well, L3 and L4. It's all moving pleura, B lines, nothing at all. So the answer was left side, there is no a leak, no need to do any further intervention. And the right side, this A profile probably bowel this baby has. So this was also my reflection on this case. Lung ultrasound can rule out suspected air leak, because if you see B lines, if you see pleura moving, and you confirm was M mode, so this is not an air leak. But be careful that A profile with absent lung sliding in all lung zones doesn't mean always invasive intervention. You need to look to other pathologies, and one of these pathologies is having a bowel in the chest. And moving to the fourth case, I hope you're getting bored so far. So this is a 35-weeker term baby, emergency cesarean section, pathological CTG, maternal PET prom, admitted to the neonatal unit in view of respiratory distress, started on CPAP, 7 centimeters in air, and X-ray showed right side diaphragmatic hernia. So it was not antenatally diagnosed. Late preterm baby with respiratory distress, no surprise. Started CPAP, but X-ray showed what you can see now. So the baby was intubated on low parameters, was in air, doing well actually, surprisingly. Right side CDH, and I'll show you the ultrasound now, but not needing a lot of ventilation. So I was on a night shift and just wanted to know what's in the chest because this baby was not antenatally diagnosed. Um, so I put the probe on the right side. Again, here you can see a profile here. This is a loop. This is just to confirm what I'm telling, that there is a loop. If this baby was unwell at birth and I put the probe and I see a profile, I would probably thought about uh, uh, pneumothorax. Also, you need to think about differential diagnosis. Uh, and as you go down in R2, you can clearly see the liver. Here, the liver is in contact with the pleura. So in the previous case, antenatally, we know that the liver was in the chest cavity, and this was confirmed antenatally and surgically as well. This baby, we don't know anything, so that's why I put the probe on, and I can see the liver, surprisingly, in the right side of the chest, and this baby was doing well, and this baby did so well surgically and post-surgically. Uh, yeah, and you can see the liver filling all the chest because the liver is in touch with the pleura. But my message here is that you still can see a little bit of A profile, not very typical, and a little bit of lung, but this is not a lung point. This is probably a bowel and lung, and the rest of the right side is just liver. And on the left side, I just wanted to comment on the aeration, moving pleura with B lines, moving pleura with B lines, no air leak, moving pleura with B lines, and also at L3 moving pleura with B and A lines, so no air leak on the left side. One more, another case, turn baby. I was planning not to put the X-ray and try to figure out together or translate or have a picture of what the ultrasound shows us, but for the sake of time, I'm
Um,
putting the
uh,
X-ray.
Ahmed, sorry, my apologies for interrupting. So we have 10 more minutes.
Okay.
There are some hands up as well. So
Okay.
is this your last one, or you got more?
So I have a couple more, but those three cases will not take more than 3 minutes. I'll just, uh, if
Okay,
you don't mind,
that's
give me
lovely. Yeah, please go
2 more minutes. Yeah, because I just want to say my message and that's it. So this is another case, another term baby delivered. This baby actually went to postnatal ward, started to have respiratory distress at 6 hours of age, admitted on high flow, started PEEP in the postnatal ward, transferred high flow nasal cannula, and X-ray showed what you can see, a left side diaphragmatic hernia. So this baby was not born in our hospital, transferred to our hospital, intubated, again, not on high parameters, not on inotropic support. So on the right side, where there is no diaphragmatic hernia, again, there is no, I was just wanted to confirm that there is no air leak. On the left side, that's what you can see again. So here on the left side, it's A profile. Again, A profile. This is bowel. So just be careful. If this baby, if we started to put the probe on this baby without X-ray, because this baby is not antenatally diagnosed, we would probably have seen a profile picture, or which could be an air leak, but we have to complete our investigation. And as you can see here, you start to see some a peristaltic intestine moving here and there, and here as well, and L3 and then L4 as well. And from the right side, we have seen the liver down, so we can say that the intestine is up. There is a profile, but it's probably a bowel loop, not an air leak. And we can see the intestine on the left side of the chest. Um, again, so again, my reflection is that profile with absent sliding is not always air leak. There are other side effects. There are other differential diagnoses. The last two cases, very, very quickly. Late preterm baby, cesarean section, um, 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 because of poor CTG, but baby cried after birth, but noted to have increased work of breathing, started on CPAP, needed oxygen up to 80% just to keep saturation within the target as per NLS. And then we will fail to wean oxygen below 60%. Baby was still working hard, intubated the baby, still working hard, 60% oxygen. X-ray is available at the theater, so we admitted the baby to the neonatal unit quickly. I requested X-ray, but meanwhile, I did ultrasound to rule out pneumothorax. And this is one of the things that we can use ultrasound for very, very quickly. It takes 1 minute. And then what you can see here in R1, can, can anybody say? Right. So this R1, this is not a liver, this is not a lung, this is a thymus. Again, it's an organ in contact with the pleura, which is not uncommonly seen. So this is a thymus, but there is no air leak. And the rest of the quickly in 1 minute on the right side, B lines, moving pleura, and A lines as well. So there is no air leak. Move to the left side. Move to the okay, sorry, I forgot to put the left side. Okay. But anyway, was just to give two messages that thymus is one of the things that we can see, and lung ultrasound is very efficient in ruling out pneumothorax in just 1 minute. If you have a baby with high oxygen requirement at birth that you don't know about the baby. This baby was a 27-weeker, the last one, 3 weeks old, perforated neck, went to theater, and then ileostomy, generalized edema, very unwell, high parameters of ventilation, inotropic support, 3 a.m. in the morning, night shift. This baby started to desaturate, bradycardia, poor chest rise. Transient elimination was weakly positive on the left side. That's how it was interpreted. And I also interpreted the same way, baby's edematous and shining on one side. We've conned the X-ray. They said they are in trauma call, and they may take 15 minutes. Baby's desaturating, going again to bradycardia. So 1 minute, put the probe on, rule out pneumothorax. Put the probe on. Left side, we can see the pleura moving. Sorry. Left side, can see the pleura moving. We can see some A lines and B lines. Right side, it's very thick interrupted pleura, coalescent of B lines. It's a right side lung collapse, and the X-ray confirmed that. But in less than 1 minute, just sweep your probe on the lungs, rule out pneumothorax in 1 minute. So my reflection on this is lung ultrasound, lung sliding and B lines rule out air leak in a crashing baby and can diagnose other respiratory disorders like collapse and effusion. So my conclusion at the end that there are strengths and weaknesses when we deal with a profile or we are suspecting pneumothorax. First, lung ultrasound can rule in or out air leak in a crashing baby, but we need to take into consideration the whole picture, the clinical findings, with the lung ultrasound before taking decision to stick a needle. There are limitations of lung ultrasound. Lung ultrasound is not able to assess the depth, and also we need more work on neonatal population specifically to find an evidence and suggestion for indications and invasive interventions for air leak, because we don't have enough evidence. And then the appearance of air leak could be pneumomediastinum, could be pneumothorax, could be cystic PBD. I didn't get a case for this, sorry, and could be bowel in the chest. So keep in mind the differential diagnosis when you find a profile. Thank you.
Yeah. Great. That was a very comprehensive, fantastic presentation. A great spectrum of pathology that you have shown, very good cases that you have shared with us. So I would just go straight to colleagues who have raised their hands. I can see Umaima had her hand raised. So Umaima, please go for your question and comments, but just be aware that there are just 4 or 5 minutes left, and there may be other people to comment. So please ask and comment. Thank you.
So can you hear me? For the first case, when you say pneumomediastinum, I don't think pneumomediastinum will give the same radiological signs. It will be air paraesophageal, but it will not lift the air between. It will not lift the pleura and give the same radiological signs. So he had the 4 signs or the 3 signs. So I don't think this was a pneumomediastinum. I don't know. What's your comment as well?
I've tried to look at the literature, what are the signs of pneumomediastinum, but I came to a conclusion that probably it's not, probably it's a small pneumothorax, but in both cases, I don't think in a hemodynamically stable baby we would intervene. So this was my eventual conclusion. But I tried to look at the literature if I can differentiate between pneumothorax and pneumomediastinum, but honestly, I didn't find an evidence. I'm not sure if other colleagues would have different opinions, but It's debatable. Even in the X-ray, it's still debatable. You would say pneumothorax, pneumodestinum. Sometimes it's clear, sometimes not.
Okay, I'm letting the crowd speak. Anybody wishes to comment?
Hi, Ahmed. Thanks. This is Mo here. Nice presentation. I'm just wondering, as you said that trying to quantify or imagine how the pneumothorax look like or the size of it is very difficult with ultrasound. Even with X-ray, it's difficult because it's a 2D image. You might get it
Yeah.
better by doing a lateral view of the chest, and that can give you some a little bit perspective into the depth of it. But sometimes cardiologists do 3D ultrasound for valve. I don't know, have you come across of any studies, most likely in the research phase now, of trying to having better estimation of pneumothorax using 3D ultrasounds?
I think so. I'm still in the learning phase, but I would say that 3D ultrasound for the heart, we are looking at an organ and fluids, and both they absorb the ultrasound beam in a different way. But then we can do a 3D picture. But the problem with air, as far as I understand, it will not allow the beam to travel at all. So it will not allow us to look at the depth, and it will not allow us to look at the 3D picture. I've seen some literature in adults that they look at the diaphragmatic movement, and they can interpret it in a way that gives an idea about quantification as well. But it was too complex for me to apply it on the neonatal population. But personally, my understanding of physics is that air will not allow us to do 3D because the beam will not travel through it anyway.
Okay, thank you.
Yeah, anybody else? Okay, so while I'm waiting for somebody else to raise hands, I would just make a small comment here. So what I would do, so there were the great cases, they were very complicated. There was, you've shown lots of pathology in addition to just the air leak. And it was great to see that you were one, exploring the lung, and you weren't restricting yourself to a certain zone, and I think that, and number two, you were looking for masqueraders who the other pathologies that may look like an air leak, but they're not. And it's a great thing that you try to make a mental picture of what the air leak is might look like in a 3D. And it was also great that you were trying to have a very clear question in mind. So I believe you cannot at this stage get rid of the X-ray just yet. It cannot. You'll need at least one X-ray. So on the X-ray, even when it does not provide an answer, it does pose a question, and that helps because then I would go for an ultrasound looking for an answer for a very specific question. One usual question pops up that you get an X-ray done and you see an air leak-like appearance, but you also find the lung parenchyma occupying and extending all the way to the lateral chest wall. So you see some margin, sharp margins, and you know there's an air leak, but then you also do not see a collapsed lung margin. And you say, okay, there's an air leak, but is it bad enough to put a chest drain in or a thoracentesis? If there's a margin of a collapsed lung, then you probably don't even need it. It's just a chest ultrasound, the decision is clear. But what when the parenchyma is visible all the way through? So with that specific question, that chest X-ray cannot answer because it's an AP view, it's an anteroposterior beam that goes in, and it doesn't. And I think it's the chest X-ray that fails to gauge the depth of it, and that's why Mo was talking about a lateral X-ray. I think that question gets very nicely answered by an ultrasound, because the ultrasound will straight away will not be dodged by the fact that the air leak was anterior to the lung, and there was not much on the lateral sides to cause a collapse. So it's just gonna tell you that there is a significant air leak. You map it, and you'll your little diagram, and you'll find out that it's anterior, not seen by the, or posterior, not seen by the X-ray, but the ultrasound will do. And so that was one little thing I thought I'll say. I still cannot see anybody else with a hand raised. And the quick thing I thought I would share is that in the enthusiasm that I have found in air leaks, it's a significant. We shouldn't be missing out what the other lung looks like from a point of view of why in the first place this air leak happened. So the other, I just would like to make sure that I'm not missing on, let's say, a generalized a granular opacification. So a background of surfactant deficiency emerging that actually led to the air leak. But I'm more excited about the air leak and not focusing that in addition to fixing the air leak, there's a need to provide surfactant also. So what the other lung is doing, and how does that look, and the spare bits of the affected lung. Yeah, so that's what I thought I would share. I still cannot see any further hands up here. Okay, yeah, so it doesn't look like anybody else has a comment. So Ahmed, this was just fantastic. Thank you very much for sharing such great cases and a list of them, so much pathology. And I think most of your the slides that gave the conclusion, they were the bullet points, they were just very comprehensive and very agreeable. So thank you very much. It was a privilege having you today. So and there's something on the chat here. Yeah, so they're all thanking you for this lovely talk.
Wow, thank you so much for having me with the team. Hopefully we'll come again with some interesting cases as well to share with the team. And thank you for keep going with this meeting. It's very, very helpful. Thank you so much, Sergio.
Lovely. Okay, thank you, and bye-bye, everybody.
Thank you. Bye.